This will be more of a tour, and I think for this audience, it's trying to convince you of how the interdigitation between this and regenerative rehabilitation is. It may seem like a stretch, but for me, it's really crystal clear. And actually, our last talk helped me with that quite a bit. Really, nothing relevant to disclose. I won't discuss the patents you've heard about. This is my slides are cut off just a little bit. What is a brain-computer interface? What are the key components of a brain-computer interface? What you see here is electrodes implanted in the brain. The goal of these electrodes is to read the neural signals. The neural recordings look like this. Absolutely critical is the ability to code what these signals mean. That then can go to a prosthetic limb, and this is the MPL, which was built by Johns Hopkins, and we've used in our experimentation. Ideally, then, what you have next is the ability to encode sensory, so this limb can sense. You can then stimulate the nervous system in some way and provide sensation, and that feedback loop then is really analogous to how our own arms and nerves work. So what about brain-computer interfaces and rehabilitation? So I think what we've learned over and over again are a couple of factors. From Fabrizio's work, one of the things we know is that if you implant stem cells and you don't give them a signal for muscle-derived stem cells, you don't exercise with them, then you actually have less chance that they'll differentiate into a functional lineage. They'll go into fibroblasts as opposed to muscle tissue. Well, what about the central nervous system? If we implant stem cells in there, what's their signaling, and how do we control that signaling? The other thing that we've learned is that in stroke studies, if you do robotic training, I think the Locomat is actually kind of the poster child for this. People could stand, if you're familiar with the Locomat, it allowed people to walk, but they could actually fall asleep while in the device. And so it's just robotically moving their limbs, and there's great research out there that shows without supratentorial, without feeling like you're in control, these robotic or FES interventions likely have limited impact. So if you have a brain-computer interface, you're actually able to then take an FES system, or maybe a robotic system as pictured here, and persons will actually then be able to control moving their arm. So that's the argument. Keep that in mind. I'll try to remember to revisit that as we go along today. So jumping to our experimentation, we were able to find a volunteer, a 52-year-old woman with tetraplegia, who volunteered to have neurosurgery. 2 of these small electrode grids were implanted into her motor cortex. This is the central sulcus right here into M1. They have about 100 tiny pins on them, and they are recording from the neural signals. This is an X-ray afterward, and we figured out how to place these by doing fMRIs. She imagined moving. The fMRI leads up, and then in surgery we place these in. As the PI in the study, I get to hit this button that injects these things into the brain. The signals look like this. You could see that before. It looks a lot like if you're recording from muscle, it's a nerve depolarization. It's a depolarization signal. And what's key is how do we figure out what these signals are supposed to mean? And actually, it's kind of almost simple in that we have this electrode in the brain. We're getting these firings, and we have our participants sit still in a chair while an arm, this robotic arm I showed you, moves back and forth across the field, of her field of view. When I move my hand like this, your motor neuron cells your cells in your motor cortex are actually firing, and we record that, and that enables us to figure out what her intent might be. So I move like this. There are certain cells that are tuned to that movement. They fire, and then the next thing we do after having her watch the arm move, we say, hey, why don't you try to now move the arm to the left? And she thinks I want to move the arm to the left, and that's what happens. We record from about 250 neurons, but only about 150 of them at our peak were tuned, or 100 of them were tuned, so tuned to a specific movement. With this tuning, then we're able to do complex tasks, and so there's the simple task here And you know, one other concept on here is degrees of freedom control. When implanting into the central nervous system like this, outside of Pittsburgh, and we're still proud of this fact, the most degree of freedom control that's been achieved is somewhere less than 3. Working with Andy Schwartz, who's the basic scientist on this, and using that decoding algorithm of this velocity-dependent movement directional tuning, we were able to do better than that. And this shows 7 degree of freedom control. This is the wheelchair controller, our participants right here. The job is to move this block up to this shelf. This is completely under brain control. You can see this smooth movement. She picks it back up again. You know, kind of amazing thing, 7 degree of freedom control. We track this over time, and what we see is that performance continues to increase. This is what random noise might have been able to do. It's entirely overestimated, but we had to put this in the paper that was published in Lancet, and her performance increased over time. It was steady. She had 7 degrees of freedom control. After 7 degrees of freedom control, we attempted 10 degrees of freedom control. So 7 gave her wrist, complete control of the wrist, complete control of end point, right? With 3 degrees of freedom, you can reach in space. 3 more degrees, you have complete control of the wrist. Our 7th degree in that original slide was grasp. To get to 10 degree, we started doing hand shaping. And it turns out that hand shaping maps really well. If we add 3 more degrees of freedom to rock, paper, scissors, stone. So she wanted to try that. She said, you got to pump up and down.
1, 2, 3, 6, 7, 5.
She tries to cheat.
Yeah, but my paper was trying to cover his paper. Okay, ready? 1, 2, 3, shoot. Rock.
So her goal from the start of the study was to feed herself chocolate. The FDA told us we had to keep the arm away from her, but we invited the FDA to the lab, and we had her shake hands with the people from the FDA. Then we're more than happy to release that restriction. And so this is her, I'm going to just turn the volume down a little bit because I laugh really loud in one of these. This is her feeding herself chocolate. Up. See if I'm blocking that. So this is their first time, her ability to feed herself chocolate. She gained a little weight over the course of this week that we set this up. There's actually some really amazing science here in how the signal changes as she approaches herself. So if you think about motor encoding, as you start to interact with objects, everything changes a little bit. You know, the first person, just skipping ahead because it's limited time, the first person who volunteered for this experiment, his name is Tim. He wanted to reach out and touch his girlfriend who he had met after he was paralyzed. Again, he had complete paralysis. And we did this, and he wanted to hug his daughter. That was one of his goals. On the last day of the experiment, we set this up, and it was kind of a special moment. But he couldn't feel anything. And our first participant had no sensation that we could actually help. She had a kind of an interesting injury, though. It was a transverse myelitis that, relatively speaking, preserved the sensory nervous system, so she could feel, but she had no control. And so we did an experiment where we moved her arm, and with her eyes closed. So could she control the arm with her eyes closed was really the basis of this experiment. And so she's got the prosthetic. You saw how well she could control it. She's blindfolded there in the corner. We ask her, just move this arm back and forth. And she says, I'm doing it. She's convinced she is. And eventually, she just gets stranded without that feedback, right? The investigator, Rob Gaunt, comes back into the picture here. and will then grab her arm and just try to mimic the movement of the robot. And as soon as she does that, she's able to control the movement again. So this works if we can integrate sensation. That's a relatively big if. So there's a couple different targets where you could integrate sensation. On that first slide, we showed you sensory. We could actually put these same electrodes into the sensory cortex, but instead of recording, we could stimulate. You can also go to the dorsal root ganglion as a place that's kind of ideal because it's just sensory, right? So you can actually stimulate there or record from there depending on your goal. This is an electrode that's actually used in humans for stimulation. And we did some initial work on this in a cat where we're recording from the dorsal root ganglion, attempting to predict proprioception. And you can see the difference between these two lines or the errors in our prediction. So we can actually decode proprioceptive, just from listening to the nerves, we can decode this proprioceptive sensation. I guess that audio in that is not there. But, and even with some variations in steps, we have carried this experiment now out into humans. One of the great things, I don't know if there's any other rehab docs in the room, but part of what we do is if they have chronic pain, you can actually clinically put a stimulator into the cord. If you steer that stimulator out to the dorsal root ganglion, you can stimulate these sensory nerve roots. And in a patient we had who had an amputation on her right side, she actually had an amputation at the level of the shoulder, we could stimulate at these various, you can see the anode and cathode here, and get this reproducible sensation. And even when we modulated the stimulation, some sense of movement. So this is one area where we can approach this a little bit. An interesting phenomenon is when we stimulated, both of our subjects' phantom pain got worse during stimulation. So they actually could feel it, but over the course of the experiment, it went down when they weren't being stimulated to a point where it was much lower. This is the McGill Pain Questionnaire related to their phantom limb pain. And part of the gating theory of pain is that they're not getting this sensory feedback, and so it ramps up. And if we can provide that sensory feedback, does it give this other aspect to us? So we had a subject who volunteered. Our first subject was explanted. We implanted another subject, and a lot of people said, boy, you got 7 degrees of freedom, 10 degrees of freedom, congratulations, do it again. And so this is a clinical test called the Action Reach Arm Test, which is a unilateral test. The normal score is less than 5 seconds, and our first participant could never do that. Our second participant, who's kind of a gamer, was determined to do that and was able to go through this test with the same 7 degrees of freedom and get under 5 seconds for multiple tests. He just kind of winged it. The speed's not the same. Without that sensory feedback, when you're watching, it's a much slower feedback loop if you have to look at your hand. The other thing about Nathan, our current participant, was that we implanted chips into the sensory cortex. So we could stimulate the sensory cortex for the first time. Again, we did an fMRI, and we saw what lit up when he imagined his thumb being touched, when he imagined he has tetraplegia as well, his palm. We then went in surgically, and what happens is there's blood vessels in the way and other things. So when you're in the operating room, it's kind of intense trying to figure out where to place these things. And for 2 weeks, we stimulated his sensory cortex and got nothing. Evidently, there's, and this, by the way, we knew that might happen from some non-human primate experimentation. And so we stimulated the sensory cortex, but then after about 2 weeks, we're in the room, they wanted a physician present in case he had a seizure. That was the main concern of the FDA, and he started saying, I feel something. We mapped that over time, no training whatsoever, stimulate the sensory cortex, and this is where he felt things. We were hoping to get fingertips. In a monkey, you put one of these things in, you cover the whole hand because their brain is small. In a human, these chips cover this. And they're actually anatomically, their layout is exactly what we'd expect from our understanding of the geography of the sensory cortex. Reproducible over time. Sensation felt natural some of the time, but we haven't had a chance to vary these signals. This study came out and was published in Lancet on Thursday this week. I always worry, and so as a visual demonstration of this feedback loop, this is,
I'm good.
Okay, here we go again.
the sensors in the hand are being controlled by this, so the robot feels the touch, causes a
Index.
stimulation. He's blindfolded.
Ring. Pinky. Index. Middle. Middle. Middle.
So he had about 80,
Ring.
87% accuracy
Ring.
on this identification task. And again,
Index.
the trigger is the torque
Index.
sensors in the hand, then trigger the
Ring.
stimulation. So there's a White House Frontiers Conference happened on Thursday, and the president came to Pittsburgh. The paper was released on the same day. There's some fortuitous timing, a little bit of arm twisting. I was asked to speak on this, and I tell you, I cannot give this talk, especially to clinicians in the room and at a regenerative rehabilitation talk, without always putting this note of caution about hype and hope, right? Our patients still need to learn how to use wheelchairs, which is what I started doing my research on. The regenerative rehabilitation can generate a lot of hype, and this certainly has. You know, I'm running around on Thursday being interviewed, and you know, so the hype of this always makes me feel like we need to put that cautionary note and make sure that we're proving things out, and we're telling patients that the cure might be out there, but they have to focus on the hard work of rehab while they're going through that period of time after an injury. So just needed to acknowledge all of the investigators on the team, our subjects, our amazing subjects who volunteered for this and then stuck with us for long periods of time. The teams actually, we published another paper after the first one came out that really listed the FDA and the funding agency, and so the team is huge if you include everybody that helps. I thank you and appreciate your attention.